Let's move on to some common skin disorders. Often, questions on step 1 will show you a picture and expect you to identify the disease process. Sometimes, you'll be given a picture and asked to choose an answer about its malignant potential. These questions can be quick gimmies if you study these facts. Many of us are all too familiar with acne. It's most common in teenagers, but can occur at any age, usually on the face and trunk. It's an obstructive inflammatory process of the pilosebaceous unit of the skin. Atopic dermatitis is an important disease to know, and you're probably pretty familiar with it because it's commonly called eczema. Where does eczema present? On the flexors of the extremities, and it itches like crazy. Usually, atopic dermatitis is just one piece of a greater atopic triad. Do you remember the other two symptoms? Allergic rhinitis and asthma. In infancy, it appears on the face, but later in life, it is seen in the skin flexures like the antecubital fossa. Atopic dermatitis is often compared to a different dermatitis called allergic contact dermatitis. While you would expect atopic dermatitis to come on very quickly since it has some allergic and therefore IgE-mediated signaling, allergic contact dermatitis does not follow the same rule. Here, the skin changes result from a delayed type hypersensitivity reaction. Do you remember what type of hypersensitivity reaction is delayed onset? It's a type 4 reaction. Because this is a problem due to contact with an allergen, what pattern would you expect? Lesions occur at the site of contact. The classic example of this dermatitis is the reaction people naturally have to poison ivy. If a patient comes in claiming to have contacted poison ivy only 30 minutes ago, and they now seemingly have a reaction on their skin, it is unlikely to be poison ivy only because it takes a couple of days for the reaction to develop. This is another great example of how questions can be answered by knowing chronology of diseases and rapidity of onset. Do you recall the molecule that is in poison ivy that causes the hypersensitivity reaction? Urushiol. What is this? It's a mole, or a melanocytic nevus. Most of the time these are benign, but every now and then a melanoma can originate from a melanocytic nevus. How would you describe an intradermal nevi? It is papular because it is solid and raised. What is this? A junctional nevi. How would you describe it? A flat macule. Now, the classic lesion in psoriasis is multiple salmon-colored plaques with a silver scale over them, particularly on the extensor surfaces of the extremities. That's the knees and the elbows. Do you recall what skin disorder occurs on the flexors? Eczema. Good. In psoriasis, when you look at the skin of these patients with microscopy, there's acanthosis. So, which layer is increased in acanthosis? The spinosum layer. There's also parakeratosis, meaning nuclei retained from the corneum layer, and a smaller granulosum layer. You should definitely memorize these findings, as their presence is usually a pretty big hint that the answer to a question is psoriasis. There are a few diagnostic clues that may help you confirm a diagnosis of psoriasis in a patient who presents with a rash. The first is the Auspitz sign, which means that when scale on the lesion is scraped off, that spot will tend to bleed, little pinpoint drops of blood. The second clue that you might get is that psoriasis is a systemic disease and doesn't only affect the skin. So what else should you look for in your patients with psoriasis? Psoriatic arthritis. You may also see nail pitting, but there can be a whole variety of disease manifestations. Let's do a quick flash quiz. If a patient with psoriasis also has arthritis, what would you expect to see on a hand x-ray? Pencil and cup deformity. Very good. Okay, so what is this? Rosacea. And what is rosacea? It's an inflammatory process that results in erythematous papules and pustules without comedones, as seen in acne. Some patients who are prone to facial flushing also have rosacea. And what happens if it goes on chronically? you may see patients with rhinophyma, as seen here. The final common skin lesion that we'll discuss is seborrheic keratosis. This is a flat, greasy, pigmented skin lesion, and it's a tumor that includes keratin-filled cysts and happens most commonly in older adults. It is classically described as looking like it's pasted on, but it can't be scraped off, and it can truly happen anywhere on the body. Are these lesions malignant? No, not as a single isolated lesion. However, one classic board's finding about this skin finding is that it can reveal an underlying disease. Do you recall the sign of Lesser Trellat? Multiple seborrheic keratoses appear rapidly, indicating an underlying cancer, often of the GI system, and less commonly a lymphoid neoplasm. What are verrucae? They're warts. These are soft, tan-colored, and cauliflower-like. If you look at them under microscopy, they show epidermal hyperplasia, or hyperkeratosis, as well as koilocytosis. Sometimes they are described as looking like church spires. There are many different types of wart, from the commonest form, verruca vulgaris, which might appear on the hands, to condyloma acuminata, which can appear in the anus or on the genitals. Which HPV types cause warts? 6 and 11 mostly. Do these warts have malignant potential? No. You expect cervical cancer with HPV 16 and 18 to have malignant potential. Urticaria is the term used to describe hives, which are in fact wheals that are very itchy. Why are they itchy? Mast cells release inflammatory markers. You can see these in a wide variety of allergic responses. Biopsy of these lesions will show dermal edema and lymphatic channel dilation. Skin infections come in two flavors as far as we are concerned, bacterial and viral. Let's start with bacterial infections. These are actually very boards relevant, particularly because S. aureus and S. pyogenes cause the majority of bacterial skin infections, which can make for difficult diagnoses if you don't try to keep them straight. We'll provide the classic vignettes for these infections. The first is impetigo, which is a very superficial skin infection, usually caused by either Staph aureus or Strep pyogenes. Are you surprised that these organisms can cause this disease? Don't be, because they are part of the normal skin flora. It is incredibly infectious. The classic location is on the face, likely on the chin, with some of the lesions rupturing, leaving a honey-colored crust on top. A virtually pathognomonic buzzword for you to remember. Does it scar? Nope, it's a superficial infection. Cellulitis is a very common disease and is probably the start of a spectrum of diseases. Basically, you should think about cellulitis as an acute, painful, red, hot spreading infection of the dermis and subcutaneous tissues. The same bugs, Strep pyogenes and Staph aureus, are implicated here. Usually, the patient has a break in the skin from minor trauma. However, you should be wary of the presenting scenario. For example, what might you expect if the skin is burned? Pseudomonas. Erysipelas may be my most favorite word that I learned in medical school. Erysipelas. Erysipelas. Say it like 5 times fast. You'll fall in love with it too. Anyway, it's a S. pyogenes infection of the upper dermis and the lymphatics, and it presents as a well-defined, demarcated area. What other skin condition affects the dermis and the lymphatics? That's right, hives. Here comes another skin infection that you've definitely heard of, an abscess. What is it? A collection of pus in the deeper layers of the skin, and usually it's walled off. And what's the bug? You can bet that it'll be Staph aureus, and most likely MRSA. So what's on the severe end of the cellulitis spectrum? Necrotizing fasciitis, affectionately abbreviated to neck fash. It's a much deeper injury and is much more serious. What's the bug? Strep pyogenes, but also by other flesh-eating anaerobic bacteria. The classic description is the finding of crepitus on physical exam, a type of crackling sound which is literally the sound made by rapidly moving bubbles of gas that is formed underneath the skin. This gas comes from the methane and carbon dioxide produced by the underlying infection. The clinical scenario will either include a post-surgical patient or a patient with a skin infection that appears to be worsening incredibly rapidly. There may be some blood-filled blisters that form quickly or a gray discharge from the surgical site. You may also see dusky gray edges. Do you expect them to be painful? Actually, they're not, because the flesh is dead there. What should you do? Get to an OR and debride. The next skin lesion is actually a syndrome called staphylococcal scalded skin syndrome. Do you recall this syndrome from the infectious disease chapter? Here, an exotoxin that is released by Staph aureus destroys the attachments between keratinocytes in the granulosum layer of the epidermis. Patients develop a generalized erythematous rash with loss of the layers above the granulosum. Classically, this disease is thought to happen in newborns and children. Two things to help confirm this diagnosis. First, you should expect that since this is a diffuse disease, there will be some systemic signs, like fever. These patients, usually kids or newborns, are really sick. They may even have an underlying renal insufficiency. Does scalded skin syndrome leave scars? Nope, it heals completely, because it only affects the superficial layers. Let's move on to a handful of viral skin infections. The first is herpes, caused by HSV1 and HSV2. An outbreak can occur on mucosal or skin surfaces, and is a very painful vesicular rash. Molluscum contagiosum is a viral skin infection that you'll most likely see on your pediatric rotation. These lesions show up in crops of umbilicated papules, caused by the pox virus. The more children pick and scratch at these, the more they spread by autoinoculation. It's a totally benign infection. Varicella zoster virus causes both chickenpox and zoster, or shingles. These crops of vesicles invariably progress to crusted, itchy lesions. Zoster will always be in a dermatomal distribution and won't cross the midline, a key clue when you look at an image. The final infectious skin disorder we'll discuss is hairy leukoplakia, which classically appears in the mouth, even more commonly on the side of the tongue. What else would be on your differential for a white tongue lesion? Thrush. The clinical distinction is made when you try to scrape it off. Thrush will scrape off easily, whereas leukoplakia doesn't, even though it may appear as though it should. Do you remember from the micro lecture what virus causes this disease? This lesion occurs as a result of EBV infection, and is usually a sign of underlying immune compromise, such as HIV or AIDS. What bug is most likely the cause of impetigo? Staph aureus.